cortisol and urinary 17-hydroxycorticosteroid. Another test used in the diagnosis of adrenal insufficiency is the ACTH stimulation test. You don't actually administer ACTH. Instead, you use a synthetic ACTH called cosyntropin. Think of it as not the director, but the co-director. We've made his ACTH clapper a different color as well, to remind you that it's not ACTH per se, but it acts just like it. So, in the heat of the moment, when the director's unconscious, throw in the cosyntropin co-director. Cosyntropin stimulates the adrenals to release cortisol, as depicted by the moon-faced actor getting back up on the set. If you see cortisol, it's a positive test. In primary adrenal insufficiency, however, this test won't work. It doesn't matter how much ACTH you give, the adrenals aren't going to budge. In secondary adrenal insufficiency, however, giving ACTH should do the trick. You've bypassed the dead pituitary and can directly stimulate the adrenals to increase cortisol. The show must go on. All right, moving on to our next anterior pituitary hormone, thyroid-stimulating hormone. When it comes to hypothyroidism, however, please don't let pituitary hypofunction be the first thing you think of. The vast majority of hypothyroidism cases, greater than 95% in fact, are primary. This means it's the thyroid itself that's malfunctioning. Rarely, disorders of the pituitary or hypothalamus may cause secondary or tertiary hypothyroidism, respectively, the symptoms of which are virtually identical to those of primary hypothyroidism, which we represent with an untied thyroid bow tie. We're talking about stuff like cold intolerance, weight gain, bradycardia, constipation, and, interestingly, slow relaxation of deep tendon reflexes. Check out the thyroid disorder sketch for more info. In primary hypothyroidism, TSH from the pituitary will actually be increased. Makes sense, right? If the thyroid isn't working, the pituitary is going to be yelling at it, in vain, to get back to work. Hello? Thyroid? I'm stimulating you. Are you not entertained? This results in a high TSH. In secondary hypothyroidism, on the other hand, when the pituitary is pooped, it's not going to be saying much to the thyroid at all, resulting in a combination of low TSH and low thyroid hormones. Low TSH is embodied by the uncoordinated wardrobe guy. Just not able to activate that thyroid tie in time. Treatment of secondary hypothyroidism, as with primary hypothyroidism, is with thyroid hormone replacement with levothyroxine. Check out our thyroid drug Sketchy Farm sketch for all the deets. All right, next hormone. What about prolactin? Well, there's actually not much to say. There are so few clinical consequences caused by a deficiency of prolactin, it's not routinely measured. That said, remember how we usually diagnose Sheehan syndrome by a lack of breast milk production in a postpartum woman a few weeks after delivery? It's caused by prolactin deficiency. Fortunately, that's the only known effect of prolactin deficiency. And since we have a pretty effective alternative to breast milk, formula, there actually isn't a treatment for prolactin deficiency. And with that, we come to our last anterior pituitary hormone, growth hormone. At Sketchy, growth hormone is symbolized by growing beanstalks. A growth hormone deficiency, then, like that which occurs in the setting of pituitary dysfunction, is represented by these bean sprouts falling to the ground. In children, the single most important clinical manifestation of growth hormone deficiency is growth failure. Other less common features include an immature face with an underdeveloped nasal bridge and frontal bossing, an infantile cherub-like fat distribution, decreased hair growth, small genitalia, and delayed puberty. Just look at that baby face. An important feature for diagnosis is comparison of the patient's chronological age and bone age. Bone age is measured by taking x-rays of the patient's arm and comparing the radiographs to control radiographs of patients of the same chronological age. Severe growth hormone deficiency in childhood often manifests as bone age that's significantly younger than the patient's chronological age. This is termed delayed bone age. In adults, the features of growth hormone deficiency are quite different, primarily because adults are pretty much done growing. In other words, most adults have turned into mere hardened husks of their youthful selves, full of bitterness and regret. So, instead of growth effects, look out for endocrine and metabolic consequences. Growth hormone is normally responsible for increased lean muscle growth and lipolysis. So in the setting of deficiency, expect to see muscle wasting and increased fat mass, usually presenting as truncal obesity. Because growth hormone is also responsible for bone growth and calcium retention, patients with growth hormone deficiency are also at risk of developing decreased bone density and osteoporosis. The longer the duration of growth hormone deficiency, the more pronounced these metabolic changes are. In a patient with symptoms suggestive of lack of growth hormone, the diagnosis can be made by looking at another molecule, actually. Insulin-like growth factor 1, or IGF-1. At Sketchy, our symbol for insulin is a welcome inside mat, emphasizing insulin's role of bringing nutrients inside the cell. But we've added our growing vine pattern to remind you that this isn't insulin. It's a molecule that looks like insulin. In reality, IGF is a hormone secreted by the liver in response to growth hormone. Once released, it mediates many of the anabolic and growth effects of the GH-IGF axis. As such, in the setting of pituitary dysfunction, growth hormone deficiency causes a measurable IGF deficiency. Directly measuring growth hormone isn't very useful given its cyclic variability, peaking at night during sleep. However, measuring the growth hormone response to a stimulation test is often used to confirm an equivocal IGF reading. Most commonly, this is done by administering a combination of arginine and L-DOPA to a patient and looking for an expected rise in serum growth hormone. L-DOPA and arginine are represented by L and R. And you see how the guy has disregarded that stop sign and started pulling on that crank in a vain attempt to get the boxer back on his feet? Normally, arginine and L-DOPA decrease the amount of somatostatin reaching the pituitary from the hypothalamus. With inhibition decreased, the pituitary is able to release more growth hormone. Not in the case of pituitary dysfunction, though. No matter how much you crank up the L-DOPA, he's not getting back in the ring. The pituitary is pooped. Fortunately, treatment of growth hormone deficiency in both children and adults is straightforward enough. Supplementation with recombinant growth hormone. Well, there you have it. Those are all the flat pig hormones from the anterior pituitary. As a quick recap, I want to bring the hypothalamus back into the equation. You see, we've been focusing on pituitary dysfunction this whole time. But what if we take out the endocrine master controller itself, the hypothalamus? Let's say we have a stroke affecting the hypothalamus. Well, it turns out that the clinical manifestations can be quite similar, depending on which hormones are affected. If the hypothalamus stops secreting gonadotropin-releasing hormone onto the pituitary decreases FSH and LH secretion, causing a secondary hypogonadism. Or if the hypothalamus can't secrete corticotropin-releasing hormone onto the pituitary then can't secrete ACTH, and you have yourselves a secondary adrenal insufficiency. The metyrapone stimulation test won't work either. Decreased negative feedback onto the pituitary won't do anything if the pituitary isn't getting stimulatory signals from the hypothalamus. You'll have a sleepy pituitary no matter what. The cosyntropin test will work, however. Giving an ACTH analog bypasses both the hypothalamus and pituitary, directly stimulating the adrenal to release cortisol. And then there's growth hormone deficiency. If the hypothalamus stops secreting growth hormone releasing hormone, the pituitary decreases growth hormone secretion. Same story there. The dopamine arginine test will also not work. Just like before, the whole point of adding arginine is to stop somatostatin release from the hypothalamus, which normally inhibits the pituitary. Well, if the hypothalamus is also not secreting any growth hormone releasing hormone, the pituitary can't upregulate its release of growth hormone. Prolactin's an interesting one. If you take out the hypothalamus, all hormones from the pituitary should decrease, except for prolactin. The hypothalamus normally secretes dopamine to inhibit prolactin release by the pituitary. So no hypothalamus, no dopamine signal, and say hello to increased prolactin secretion. A commonly tested scenario also involves severing the pituitary stalk. Lose signals from the hypothalamus, and pituitary hormone production drops. Again, except for prolactin. You've cut off that inhibitory dopamine signal. Now, this whole time we've been talking about tumors down in the pituitary pressing on the gland and decreasing hormone release. However, if a tumor is high enough and pinches that stalk, you've effectively cut off the dopamine signal and prolactin increases. So be careful. Even an adenoma can result in a paradoxical increase in prolactin secretion, Just remember that the lesion has to involve the stalk or above. Whoa. Okay, looks like another film crew needs to use the set. So let's wrap this thing up. Perfect opportunity to briefly talk about those posterior pituitary hormones we've been disregarding. While the anterior pituitary secretes those flat pig hormones, the posterior is responsible for only two: oxytocin and ADH. Oxytocin is utilized during childbirth to stimulate uterine contraction, and breastfeeding to cause breast milk letdown. Hence the oxytocin ox there, feeding her calf. Okay, what is that prop for exactly? Anyways, while oxytocin deficiency causes problems during these particular times, it's pretty straightforward to give some exogenous oxytocin or oxytocin-like drug to replace what would normally be secreted by the posterior pituitary. On the contrary, a deficiency of antidiuretic hormone, usually abbreviated ADH, can get pretty complicated. A lack of ADH secretion by the posterior pituitary results in diabetes insipidus, a condition characterized by inappropriately dilute urine, polyuria, and hypernatremia. At Sketchy, it's represented by a dilute urine fountain. Don't worry. We'll cover diabetes insipidus in the posterior pituitary disorder sketch towards the end of this chapter. The important fact that I wanted to convey, however, is that ADH is made in the hypothalamus, not the pituitary. It's just how the posterior pituitary works. ADH is made in the hypothalamus, sent down axons into the posterior pituitary, and stored in nerve terminals. Turns out that a pituitary lesion by itself usually does not cause diabetes insipidus. The hypothalamus has extra nerve terminals farther up that persist, and you release ADH just fine. Injure the hypothalamus, though, and say goodbye to ADH secretion. You're taking out ADH right at its source. So we've placed a torn hype poster right next to our diabetes insipidus fountain. Bashing the pituitary just isn't enough. And cut.
Nice. Someone, please get that sheriff kid away from the craft services table, for God's
Great work,
sake.
people. Hey, Sylvester. Sylvie, buddy. You did so good. I liked the anger. Now, this time, maybe, hear me out. Talk so people can actually understand you. Why don't we give that a try, okay, champ? Oh, God, these flowers. Where is that intern? Brayden!